That's where it started. I forget where I get off the track sometimes. I'm in front of the other. I look at my diary on Sunday night and say, where am I supposed to be this week, or what am I supposed to be doing this week? We talk about in my 40 years of practice management, I suppose I've seen a lot of change. A lot of people in this room have seen a lot of changes in film. But my comment to you is this: if you change you see the last 5 years is nothing like we're going to see in the next 5 years. That's because it's a revamp of our whole healthcare system and the way in which we do business in healthcare. I say the word business because you're actually running a small to medium enterprise. You're actually running a business, a multi-million-dollar business. It just happens to be in health. And of course, I'm going to talk about your vision and your mission and your values in a moment. What does that mean as a result of the service you deliver to your community? But I'm still running a business. And we've got to be sustainable and viable in this. There's only so much money in the world that governments around the world are grappling with in relation to healthcare as against GDP growth, GDP spend on health. And everyone's in the same boat. We are no different than anywhere else in the world. And governments are struggling worldwide. How do I deliver quality care to our community for that pie of money, which is exactly the same? Somehow we're going to cut this pie up into various parts. Governments around the world, as they've been challenged around this, they're looking at new ways of delivering health. As I said, Australia is very different. So what do we have to get from Australia? Well, I want to give you 2 words, right? Volume, I'll take 3 words. No good at maths. Volume to value. Please think about those 3 words. Volume to value. We're moving away from the ka-ching of an item number by volume to the value of being reimbursed for the value of this of what the services we deliver to our patients. And we can debate if that's right or wrong, but that's where we are. So if you think that item 23, ka-ching, item 44, 36, think again, because that's not going to be the future. Government has been, especially sent from government, we are only going to see only 60% of our revenue come from item numbers. 40% of our revenue is going to come from other payments. The My Medicare process is the start of the journey. This is the start of the journey of a 2 to 5 year journey. The My Medicare process, the government said, is a 2 to 5 year journey. It's not November the 1st, because we actually started early this year with the My Medicare process, and that was the Deputy Secretary of Telehealth. Now we've moved into GPAC. We're going to move into high flyers from the hospital system through the PHN identification. Now we've got November the 1st moving, which we'll talk about in a moment, because the framework was released yesterday. I just sent it to Jen, the framework, what's it look like. Item numbers have been identified now, but no dollar value. But the dollar value bit, the government said is that what we received before in the EPC program is now going to be harmonised over the chronic care plan process. We know that TCAs are gone, and your referrals for allied health will be by your normal referral process, by letter. And that's what that will be. There's going to be 2 reviews over that period of time, and we'll be paid for those 2 reviews. So as you can see, and I'll talk a bit more about what I think that process is going to look like in a moment. The amount of change which is happening on the government's agenda at present, there are a number of documents, Jen, and Deb, which I'd actually like you to highlight and send to everyone here. Firstly is the 10-year healthcare plan, 2023 to 2023, 2032, that 10-year plan. Secondly, there's a Strengthening Medicare Task Force review set of recommendations as well. Those 2 documents actually set the framework of what our future healthcare is going to look like, those 2 documents. One's got 128 recommendations, and the other one, I don't know how many, it's like the Medicare Task Force review. But that actually sets the framework of what our future healthcare is going to look like. And again, you're going to have to read those documents because that's the blueprint for the future. Of course, there's another review going on, and this is a workforce review, scope of practice. That big document that says, well, how can I get staff in my practice to work to their scope of practice? Like how far can the nurses go? Are there new positions like the medical practice assistant role, etc.? Where scope of practice sit as well? What are the barriers in relation to getting new GPs and new nursing staff in a primary care. Notice what is primary care? General practice is part of primary care. So we now need to think of what does primary care mean, because we're talking about this holistic approach to delivery of health. There's some other documents as well that the government have identified and they're working on now. But as you can see, change for change's sake is not good. Change for survival is critical. No change means we get left behind. My father said to me years ago, he said, son, you can't fight, you can't buck City Hall. And I've always thought about that. I've fought City Hall all my life. I'm in there fighting at government levels for what actually happens at grassroots level. Sometimes government listens, sometimes government don't. But you've got to remember, the will of change is around the government of the day. Do they feel that change, can I make change happen? Or with my Medicare, it's going to happen. It's not going to go away. So we've got to start to rethink ourselves around volume to value. And what does that mean to my practice? About the value component. Voluntary patient registration. You know, we're all struggling at present, aren't we? To convince our patients what's in it, what's the WIFM, what's in it for me. It means nothing in my practice. We don't do levels. I'm telling you, we don't want to do long. GPAC, not really no. But November the 1st, yes. What's in it for the patient and what's in it for you? Interesting about November the 1st, a patient can still receive their care plan from your practice or their usual GP. Notice the word usual GP, right? So at this point, government cannot say, I can only get a registered patient, can only get their care plan from you and no one else. They can't do that because it breaks all the legal law there is in the land of Australia in relation to Control Trade Practices Act, a whole range of Indiscrimination Act. So I actually think what's going to happen, this is just me speaking, because I sat on the MBS Task Force review back in 2019, where things are happening now, what we recommended in 2019. I think there's going to be, this is my personal view, a disparity in relation to fees, where it'll be a disincentive for that patient to receive their care from another practice. We're not going to get $152 up front for doing the plan, not at all. Not at all. So I don't think we're going to get a ka-ching of 150, whatever the item number up front for the plan is. We'll only get a small amount. We'll only get $8 value. What's going to happen over the life of that plan, we're going to have ka-chings. 1 review, 2 review, final action plan, all over the 12-month period, 18-month period. Which leads me to a really important part. And this is the thing called TVM. You know what TVM is? It's not a model of a car, electric car. TVM, time value of money. This may be a concept which is, some people are going, yes, I know what this means. But unless you have an effective recall system in your practice, you're going to lose money under my Medicare. You're going to lose money. Because reviews will have to take place at certain times over that 12-month period. And if you don't get that patient in for that review at that time period and push it out, if the review's due in, say, 4 months, use that as an example. If you then don't do that review for 6 months, you've lost 2 months worth of money. Because the next one will be done in another 4 months' time, and then the final year, it's actually pushed the 12 month out now to 14 months. So recalls and reminders are the key. I can't stress enough, are the key to managing the ka-ching over 12. I use the word ka-ching because that's what it is. Over a 12-month period, taking into consideration the reviews, the 2 reviews, the upfront and the end. You understand? You think about that. You understand the process on it? So we need to invest in effective recall and reminder systems. And that's where, if we don't do that, we're going to be behind the 8. Just remember, I don't believe you're going to have all that money up front and prepare the plan. It's going to be harmonised. Great word, isn't it? It's going to be harmonised over the period of the plan. So we'll get the same dollar value if we do the things that we're supposed to do with the timeline by which we do it. That's the takeaway message today in relation to that. So change, that's seen nothing yet. Any questions around that? Just before I move on. I just want to set the framework in relation to, general practice of the business. The model of business has changed. Yes?
Not really to do with that. What you said before about mental practice.
Yes.
So that's like a new role that's coming into GP. Do you know from your experience, can they assist with health assessments? Can they do in their time with county boards?
Yes.
Like a nurse?
So there is no, you read the MBS, it doesn't say the category of person who can do care plans. It doesn't say that.
Oh, right, yeah.
A social worker can do it for you if you employ them and they're trained accordingly, they do the things they need to do. MPA, I have an MPA in my practice. I wrote the course for the MPA for the UNE partnership, so I know the course very well. Yes, they can do it. In my practice, my nurses don't do the care plan. They spend the 45 minutes or so with the patient to generate the data, which is required for the doctor to drop in, you see. So it takes the doctor 10 minutes versus, 45 minutes accordingly. So it's really about the collection of the data. The most important part of who is doing your care plan data collection is they have an understanding of what they need to collect accordingly. Anyone can do it. Anyone can do them. So this is where the government's talking about the scope of practice. Who else can we do? Who else can do this? Are nurses working with the scope of practice? Most practices they're not, because it's about trust. Scope of practice is about trust, the relationship between the clinician and their staff. It's like practice management. How much do you do? How much you don't do? It's about trust between you and the owner. So what are we going to talk about today? We're going to talk a bit about strategic planning, business development, and a bit about financial management, sustainability, and what is going to be your role in relation to the knowledge which you've got to gain. So the topics I'm going to start on about strategic planning, talk about some business development and financial management, conclusion, and then we'll 10:30. I think we finished, Jen, don't we?
Yeah.
10:30 from there. Please ask questions as you go through. I learned a long time ago, the knowledge I've gained is not for me to keep. I'm a custodian of information. Someone's given it to me, and I'll give it to you. And that's why I've written the book on the principles of healthcare practice, because someone's given me this 40 years worth of knowledge. Give it to someone else. You're no different to a house. You're a custodian. You own it today, tomorrow someone else will own it. Like your car. Someone else will own it tomorrow, but someone else will own it tomorrow. So knowledge management is no different. And I think one of the challenges for us in these evolutionary times, the change in healthcare is around how do I manage knowledge? How do I manage knowledge? And I think that's a big challenge for us all. The number one risk on my doctor's risk register, I have 9 owners in my practice. The number one risk in my practice, our practice, is me. My owners have said, Gary, you are the number one risk in this practice. You're 68 years old in 2 weeks' time, and you're walking out the door. Because if you walk out the door, that's 40 years of knowledge of our practice. I thought about this. But what am I going to do? Oh, right, book. But secondly, what am I going to do for the practice? So I've started up a spreadsheet. For each month down the left-hand side, across the top, the general areas that I do, and what I do each month, some of those areas. I sat down and I just populated what do I do each month. Certain things I need to do. So if I'm hit by a bus tomorrow, if I walk out the door, someone can look at that document and say, oh, August each year, he organised the Christmas function. Very important. It's got to be on the spreadsheet. It's got to be on the spreadsheet. So how do I not manage knowledge? There are 2 types of knowledge. What are they? Anyone know? There's foundation and there's currency. There are 2 types of knowledge. What we're going through the changing of our healthcare system is currency knowledge. So that changes every day. Foundation knowledge of building blocks, IR, HR, practice development, those information management, human resource management, dare I say. They're the foundation knowledge. But currency knowledge is the stuff that you're doing today. And the more currency that you can get creates a richness within your organisation, that knowledge management. So let's have a look at this. Well, Strategic planning. This can be done in a number of ways, strategic planning. And it's really important somehow. We've got to have our reason for being talked about in a moment. But even more so now than ever, we need to strategically think about who we are and what we are and where we need to be. Now more than ever. So what is your strategic direction between the next 2 to 5 years? Maybe you don't know what you don't know. And that's the great thing about your PHN. They can feed you the information that you need to know. But you also have responsibility as a practice manager or a practice owner is to start to do your homework yourself. What's my practice going to look like tomorrow or the day after? Because it's got to look different. And strategic planning is the only thing that will do that for us. And one of the big things about strategic planning is based around organisational culture, practice culture. That's not KULCHA, it's CULTURA. The strategic planning under these 3 areas, your vision, your mission, your goals, objectives and values, are the things that actually set the culture of organisation. And especially in change management and leadership, we are all leaders in our own right. Whether you're at the reception of the front desk, you're still a leader, or whether you're a nurse unit manager, or whether you're the owner or a practice manager, you are a leader in your own right. And leadership plays a big part in relation to the vision, the mission, the goals, and the values. So when we're talking about the vision, it's a statement of being. Do you have a statement of being? My reason for being. I want to provide the best healthcare to all the people of Mackay. That's a great vision. Have you got a vision? The statement, unless you have a vision, you cannot start to build around the decisions which you make. Now, most organisations that I'm chair of, and I'm chair of about 5 organisations, the vision sits at the head of every agenda, right at the top. So any decision we make in a board meeting or a practice meeting always reflects back to our reason for being. How do we provide the best healthcare to all people? Every decision I make is based around this whole aspect of aspirational statement. Aspirational statements are great in relation to a vision. But Jack Welch says, good business leaders create a vision, articulate the vision, passionately own the vision, and relentlessly drive it to completion. Unless you actually have support of the owners of your practice in relation to the delivery or setting of a vision, the culture of the organisation will struggle. It's like a run of a ship. There's no direction. There's no reason for this. Very simple statement, vision statements, as I said. Our reason for being. This is a rhetorical question. Who actually has a vision statement in their practice? Yeah. Right. Is it public? It's public. Remember your vision, your mission, your values, and should be a public-facing document. And we are going to be judged by those. Our community will judge us by, externally, by our vision, mission, and our set of values. But we need to measure ourselves against those internally as well. So let's have a look at the mission. The mission is the doing bit. The mission's the doing bit. I'm saying my vision is this, but I'm going to do this to make my vision come to reality. So the mission is actually a written document that says the how. The vision is the why. The mission is the how. How am I going to achieve to provide the best healthcare to all the people of? And I think that when we look at this as what Jack Welch said, good business leaders create a vision, articulate the vision, passionately own the vision, and relentlessly drive its completion. But the mission is actually the written document, the set of your organisational purposes. How am I going to make my vision come to reality? It's a written declaration of your core purpose. So do you have a mission statement of how you're going to achieve your vision. These should not just be words. Historically, we say, oh, I've got to have one because maybe the accreditation organisation or the colleagues understand and say, we've got to have, I'm just on the side. The 6th edition standards are just about to be released. I've had a sneak preview of it. Because I'm a director of AGPAL and a surveyor of 27 years, so I've had a look at them yesterday, actually. Now, AGPAL's got the contract to do the pilots. 10 practices have to go through the pilot by the end of September. There's another 30 practices by December. So if you're coming up for a accreditation between now and the end of the year, you may be asked by AGPAL to participate in the 6th edition standards. Interesting. 6th edition.
4 days.
Well, you get 4 days.
Oh, yeah, I said not 4 days.
No, I don't think it's no. So 6th edition is on its way. The pilots will carry it out this year.
They're being carried out.
They're starting in the next couple of weeks, I think, next few weeks. AGPAL have got a contract to roll out the 6th edition. But if anyone's going through them, they'll be set against the 5th edition because it's only a pilot. 2025, there'll be an option, maybe the second half of 25 to do the 5th or the 6th. And I believe that'll be January 26th. It'll be compulsory. Look at the price of the 6th edition. That's sort of the rough timelines of that may look like. How do you get on to that? How do I get on the standards here?
Just being a pilot. You just said as an aside.
Oh, on the side.
Yeah, that's all you say. He's just like, oh, as an aside.
On the side. I go back as on the side. I go on the side quite often. So what was I doing? What was I doing, Jeff? The how. That's right. Yeah. The mission becomes the how. It's the written document. How do I achieve what my vision may be? And these fall into these things called, which we have, when we put the hows together, there are a set of goals and objectives. And goals and objectives are really important because they're the things that we can tick the box and say, oh, I've actually done that. Like accreditation. And accreditation is a good example of achieving your vision. I want to provide the best healthcare to all the people in my local area. Now, part of that could be accreditation. Because I see accreditation different from other people. I'm a little bit dense in quality. I don't see it as a compliance process for our PIP QI, which I'll talk about that in a minute. The incentives program. As an aside, even I'll talk about before I got onto the side, right? You are aware, or you may not be aware, that P810 will know that they're reviewing the PIP program, Practice Incentive Program. You are aware of that? Good. Now, when's the next one? Next 29th, is it? The next webinar?
Yes.
The department started a webinar on the 29th of August, between 12 and 12:45, I think it is. Where you can provide some feedback and listen to the discussion. Now, remember I said before, what time are you finishing? 3 o'clock.
He's teasing.
Remember I said only so much pie to go around. I said that earlier on. Seems so long ago. How are they going to fund my Medicare? Well, they're going to fund it, I think, by existing buckets of money they have. And we're going to find the PIP program, Practice Incentives Program, the PIP QI, and the WIP may be slightly different. Where does that fit with my Medicare? Hey, uninitiated person like myself going to say, we've got a bucket of money over here in PIP. I'm going to think about dropping this over here into my Medicare. I think. And some of the quality requirements around my Medicare will be part of the incentives which are going to be paid in the my Medicare system. Because we know full well that there are 2 components to the my Medicare. This is nothing new because if you look at the program so far, there's a clinician payment and there's a practice payment. So we're going to find, I think, those PIP monies dropped into quality agenda money. So here we're talking about volume to value. Government's going to reimburse us for the quality that we deliver to our. Bodenheimer's 10 building blocks of high performing care. You know all about it? Primary care.
Yes.
You know Bodenheimer's? Well, I'll tell you what. If you know about Bodenheimer's, wait, Miss Mills over here, and I'll give you a lecture, a 3 day about Bodenheimer. Because if you look at Bodenheimer, that is the framework by which our healthcare system is going to work under. Team engagement, voluntary patient registration, data-driven outcomes. They're all there. Leadership, they're all there. They all fit in the building blocks. Now, before I got to an aside, what was I talking about? Mission, vision. The importance of how it will be measured. Your mission, your goals in relation to your mission are the things we're going to measure. Have I done accreditation? Yes, I have. Have I done that newsletter? Yes, I have. So the doing things are so important. When we set our mission statement, we have a set of goals and objectives. Now, the two types of goals and objectives, financial and non-financial. I'm not going to go into each of breaks those. But when we're setting our goals, think of the financial goals, think of the goals. But the next one is this thing called values. Values. Generally in values, we have, these are what we call operating principles that guide us to our internal conduct. And generally values are set things like integrity, trustworthy, honesty, whatever they may be. Just about 5. We have these set of 5 values. And values are really important for the structure of your culture organisation by internal and external. I always suggest when we have staff meetings, we should reflect upon our values. Are we ethical? Ethics could be a big part, could be a value. Honesty, integrity. There's a whole range of these. Sorry about the ball patch and reflection. Sorry about that. The great thing about values, we move from and the importance of leadership in setting the values. Unless our values come from top down, we'll struggle as an organisation. There has to be support, whether it's owners support or practice managers support. And these values, respect and collegiality, diversity and inclusion, leadership and integrity, excellence and discovery. These are the values. And sometimes our values are encapsulated in documents, code of conducts, grievance policies, even down to our disconnect policy in relation to the new legislation. If you're who has less than 15 employees in practice, for the disconnect policy and those policies, so new policies, Fair Work laws don't apply because you're defined as a small business. If you're 15 or more, there's new requirements around things like the disconnection policy. And the new casual determination, the new requirements on casual employment now changes. That's from end of August. You know all about that. As an aside, no, I'm not going to go there. But there's new laws. That's from September the 1st around definition of casual employees, and just so Fair Work has some documents around that. And don't forget, and this has part of culture and part of values as well. Do you actually provide all your staff with that Fair Work Act one-page statement in relation? Well, there's a new one out now, so just be mindful that there's a new one out. And how often you now need to provide that document to casual employees. That's changed as well. Every 6 months for a casual who for 15 and above and 15 and below, it's once every 12 months. So there's new requirements around that. There we go. Oh, I'm on the upper slide 3.
No on the sides anymore. No side trips.
No, my whole life side trips. One of the things about building culture in our strategic planning thing is what we call shared purpose. We've spoken about our reasons for being. We spoke about setting our goals. But this is for me what's called a goal congruency. Goal congruency means an interdependence. Both these mean that the relationship that we all have together mean that unless we work together, we'll never achieve an outcome. Just think of the cogs, the wheels on a cog. If one of those cogs is missing, one of those little pieces are missing. So when the cogs go around, it hits there and it jumps, throws everything out. Shared purpose is exactly the same. Are we all on this train together heading to If not, get off. But there are going to be times in relation to shared purpose, this train pulls over at Catherine and parks at Catherine for a day, everything goes and does a side trip. Then we get back on the train again and get off the dump again. So shared purpose is important. And part of this whole culture component, shared purpose is what happens when a group of individuals aligns their belief systems or values with common challenge or a vision or a goal. So we've all got to have and live and breathe the values and the vision of the organisation in one form or another. That's why it's important, as I said, you need to keep revision in good strategic thinking. That we all are aligned with what we're trying to achieve at the end of the day. That's why the best healthcare people are. So when we're talking about this shared vision, I want to quickly show you a TED talk in relation to what I call why. See where this works. The why. Now the challenge for all of us in this change management process, whiteboard, draw a when we drove that, the bell curve like this, and there is, I have slightly different figures, 15, 15 and 70. First 15% say, bring it on. These are my early adopters. Bring it on, I'm happy to run with this now. And there are people out there who are very heavily involved in my Medicare now, and they're ready to go, etc. They bring it on, I'll worry about the issues later. There's 15% at the end, the laggards, they'll never come on board. They just won't do that. We find this in accreditation. There's 15% of practices out there that are not accredited for a whole range of reasons, and that's fine. But the 70% are the people that you and I have to worry about. Not the early adopters, not the laggards, the 70%. And remember when you drew that line between the 15% and the beginning of the 70%, there was that bit in the middle. Our challenge is to shift that bell curve to the right. That's the whole thing about change management and strategic thinking. Shifting that bell curve to the left, which then starts to get the thing about the why. The why is the most important bit. That whole scenario around Apple, the whole scenario, you know, been to Dubai, right? Dubai had taken the view, build it and they will come. Really couldn't care less. We build it and they will come. And Apple are exactly the same. They've got the why right. Not in relation to, I'm going to think about this. I read Elon Musk's book going back some time ago. When I posted something on LinkedIn and say this man pushes the envelope, someone came back and said, no, he doesn't push the envelope, he creates the envelope. And how true that is in relation to good leaders and the why. We create the envelope. I think that's a challenge for us all in our strategic thinking. We need to do things differently. If we're going to still use the same old box, the four walls to the side, the roof and floor and whatever it may be, a cookie cutter, we want to survive. Good strategic thinking, good vision, good digital, good values, all based around a new way of thinking. Unless you change your way of thinking in the next 2 to 5 years, you will not survive. Sorry to say. Volume 2 minutes. 5 years' time, you're going to say, I don't remember this old fella. He mentioned those three words, 40% and 60% worth of funding. That's the reality. So, part of our thinking around whole aspect of strategic planning is this thing called the quintuple aim. Now, you may not know about the quintuple aims. You may have heard about the quadruple aim. You may have heard about the triple aim. And this is, in 2007, in the healthcare sector, we talked about the triple aim. What was it? Well, it was improved patient experience, better patient outcomes and lower costs. And this is international, it's not Australia. This was an international set a framework by which we had to start to think about the importance of our business. And then in 2014, someone said, oh, yeah, it's great to think about all that, but where does the clinician fit in this? The clinician well-being. So then we had to start to think about in our planning about clinician well-being. And then in 2021, someone thought about health equity. Health equity. And this became the quintuple aim. And health equity now is so important for us, isn't it? We're going to find that some of our funding will be based around health equity. If we look after the disadvantaged and vulnerable populations within the system, health equity in relation to access to care, health equity in relation to how we deliver our services. We've got a diverse population now. The poor are getting poorer. The wealthier are getting wealthier. The middle society is actually getting poorer. I was reading a book by Hugh Mackay at present, the social scientist, a very, very new book. So we don't read any Hugh Mackay books. Great social scientist, well known. And he talks about, I've just finished reading a chapter about equity, what's happening in our society with equity. So the challenge for you and I is around bulk billing versus private billing, isn't it? And we're saying to ourselves around for sustainability and viability of healthcare, we need to move towards private billing. But what does that mean in relation to health equity, which is access and and all those things that come along? What do I do? What do I do in relation to bulk billing? What do I do for under 15s? What do I do for aged care pensions? This becomes a real challenge for us all in relation to health equity and quadruple aim. It's really hard. Let's move towards blended payments in the last 18 months. Yeah. I saw some research the other day that something like 86% of general practice in Australia have moved to some form of private billing. Which actually sends a message, doesn't it? Well, we've done the same. Yeah, we've done the same. So where's health equity fit in relation to you're thinking about the quadruple aim and you're sustaining a bulk billing practice? We can sustain a bulk billing. 84% of our patients, 84% of the service we provide are bulk billing, because we have scale. We have good infrastructure system. I've got 7 nurses in my practice, mixed between EENs and RNs and MPAs. Where they do all that grunt work and process work, etc., which we require. It's called vertical integration. Why the dog and bark yourself? It's a concept and philosophy. Where does health equity fit in relation to quadruple aim when you're thinking about the strategic? Because if you have a value of equity and fairness, it can be quite challenged as that value of your practice if you're going to sit back and start thinking about private billing. You've got to think about your value of fairness and equity. One of your values could be access. So you need to reflect back upon the things that you do every day strategically within your practice, back to your values. Not the fact you're not going to go to private billing or increase your private billing, not at all. But think about, are there different categories within our practice we need to start to think about? So think about the quintuple aim and think about health equity. Yes. Yeah. Sorry, yes.
Yeah. So it also depends on the majority of your patient base.
That's what I'm saying, yes,
Yeah, so for us specifically, we have predominantly elderly people. We have a policy where anyone who was age over 70, they're bulk billed, and anybody between that will be privately billed unless they've got a concessional card.
Yeah.
And we sole GP, we have still managed to float by and make that work. But elderly people generally do have a lot of issues,
Yeah, they
and so
do.
they come back a lot more, so they also touch onto that.
The challenge with us, when we think about there's no right or wrong in billing policy, none whatsoever. There's no right or wrong. No one says you've got a bulk bill, no one says you've got a private bill. That's a decision of the owners of the practice to make that call. And you make that call to determining what your cohort patient is, for sure. But what we also need to think about in this is that where does this become viable or sustainable for me in relation to, so is there anything within the infrastructure that I can say I can put an extra 2 patients per hour in the doctor's appointment book by someone else doing that? Right? So all of a sudden now that's another, what if your bulk bill, it could be another $100 or $150 or whatever it may be into that 1 hour by putting 2 more patients in because someone else is doing something for them.
Yeah. The thing is though, the Medicare items don't allow for that much at the moment. Like if there's like 109.97, but other than that, there's not a lot. So I would hope that Medicare will eventually bring out some more item numbers to help to.
When they increase the item numbers for nursing staff, that's not off the table. I think in the Medicare system, with my Medicare system, there's going to be, and this is why there's going to be a practice incentive within the system as well as a doctor incentive within the system. Fine? And that practice incentive then becomes a support mechanism of how you utilise that extra practice payment within the My Medicare system.
Outcomes or anything?
Oh, we don't know. Look, we don't know. We don't know. This is called pay for performance.
Okay.
And in Australia, our colleges and our AMAs do not want pay for performance. They're quite open about this.
Yeah.
Government. So, because pay for performance also has an effect upon, it's driven by the patient as well. And why should I be penalised if the patient does not? What if you 10 point, any nurses in the room? Oh, she's gone. HbA1c at 12.5. Those people will never ever comply. So why would I be penalised on them to get that person's 12.5 down to 6.7? It'll never happen. So a lot of it has to do with the patient as well. I'm just going through my recall list of my staff. The number of patients who we've had 3, 4, 5, 6 contacts with. I'm not going to waste my time on those people. Take them off the recall list. So if I just pay for performance, I won't be paid for those 3, 4, or 5 phone calls, letters who should be back for their GPMP reviews, etc.
Yeah.
So I'm going to be challenged around that. So my pay for performance, if that was the case and the outcomes, will be a challenge.
Yeah.
It may be. There may be big picture stuff. 25% of our patient base, national average for diabetes type 2 is 12.5%. Whatever it may be, it could be national priority. I don't know. But all we know is at this point in time, aim to get them a run.
Mentioned to Sue, like, with bulk billing, the elderly demographic, a lot of the time they take a lot more effort. Like, they might be on 10 medications and you're getting less incentive or less payment to see them. It kind of, so it makes it.
In the area that I'm in, the doctors are retiring everywhere.
Yeah.
So we're picking up now all these older patients from well-established GPs that are walking through the door because we're still bulk billed. Now, the challenge with this, of course, for us, in relation, where's fairness here in relation to our values? Where's fairness? Fairness to my existing client who's been with me for 40 years versus the new patient who walks through the door. Why should my patient of 40 years be penalised? Can't get an appointment because I'm getting an immune influx of patients. So I don't care who you walk through the door. It's $95 first up and profit bill thereafter. I cannot, it's not fair and it's not equitable for the patients I bulk bill have been my patient for 40 years.
So just an aside as well, but with the old patients who have come from established GPs, but an issue that we've seen is that one of our doctors previously would spend an hour and a half with their patients, and that patient had the expectation the new doctor would take that,
That's right, yes. Yes.
which would put him behind with all the other patients, which was an extreme challenge for us to say, no, we know this previous doctor used to do this and they used to bulk bill you every single time. But this new doctor you're seeing will not take that on with you and you will be expected to pay at the end of your visit. Please do not just walk out the door.
There are two components to this. It's expectations and obligations. Our patients' expectations or obligations.
Yeah.
And this is about setting the framework. It may happen first up, but what's the framework? And it is what we call house rules. What's your patient charter? We're the patient charter. And it's given to every patient who walks through the door. Your responsibility as a patient, my responsibility as a practice or a clinician. And everyone's given those to every new patient who walks through the door, and they are the house rules of how they interact with us. Set the framework.
Yeah.
It is a challenge. We're going through that at present
Yeah.
because we're getting 3 local doctors retired. We're getting their patients. They just walk in and say, "Oh, I want to see a doctor. I want to see Dr. So and so." No, it doesn't work that way. So when we're talking about our strategic plan, all these things we're talking about, one of the things we need to do is what's called our SWOT analysis: strengths, weaknesses, opportunities, threats, or the other one's called a PESTLE. PESTLE. And then in that, it's about the environment. And the environment is changing so much, as I said before, regarding my Medicare. So we're talking about business development. This becomes a challenge for us. Do we need more patients? Do you need more patients? Generally, we don't. It's about the retention, looking after the ones that we've got. So we talk about business development. It's more not so much I want more patients, I'm going to go to the marketplace. The last thing we want is more patients because we can't deal generally with this. We can't deal with the ones that we've got. So when we're talking about expanding of services, patients growth, marketing and outreach, all these points here is about how do you develop your business? 2 ways of business development, externally and internally. Business development can take place internally. This is where strategic thinking takes place. What do I need to do things differently? Just because that system we've been using for 25 years doesn't make it right. How often? Sorry, I take over there.
No.
I think it's copy this presentation again, are they? Yeah, they're going to copy it.
Yeah.
Oh, the knowledge I've gained is not for me to keep.
Okay.
The knowledge is now yours. What's I talking about? Oh, internal and external.
Yeah.
Business development is internal and external. Internal is the revision of the policies and procedures and processes and systems. Never ever assume as a practice manager or an owner that what we did yesterday is right for today. So I'm telling you now, with my Medicare, every bloody system in your practice is going to change. When you know how to change. This is called my you will to change. You will change when you know how to change. That's the number one you will aspire to. You will change when you know how to change. You will change when you see a benefit in change. So the you wills of change are really important in change management process. I'm not talking about change management. But internally, in relation to business development, externally, why do I invest all that money? Give me an example. 98.5% of my new patients, and last month was 594 new patients last month. 594 new patients last month. It's good. Is it good? So there's 594 new patients now that have got to fit into our appointment system. Of those 594, 98.6% of those 594 came to practice because of the referrals. Patients of the circuit. So why do I need to spend $1,000, $10,000 on social media promotion of my practice? but 98.6% walk through the door because of referral by patients or research. So we try business development. Where does this fit in the big picture of my marketing strategy? Do I need what social media stuff? Do I need LinkedIn? Do I need Facebook? Do I need all this other stuff? All you mean, it's all about money. So they're the sort of things we need to sit back and say to ourselves, well, what drives internally now in relation to business development? How do I provide a better service internally to my patient? Because the cost to retain a patient is effectively zero versus the cost of getting a new patient through. So how do I retain what I've got? And that's the big thing. It's like staff. I'm not going to talk about staff. Oh, no, the bottom one here. But Westpac Bank did a survey going back 15 years ago, and they say get a new staff member up to a level by which they are providing a return to the organisation was 85% of their first year salary. 85% of their first year salary, direct and indirect cost. High staff turnover, loss of income, high revenue, all that sort of stuff. Cycle of poor performance. So what's the cost to keep? What's the cost to keep? Well, I've been there 40 years. My office manager's been there 37 years. My supervisory nurse has been there 36 years. Average nurse, above average, 17, 18, 19 years. Receptions are in their 20, 25 years. They won't leave the place. That says something, doesn't it? So when we talk about business development, staff development plays such a big part. What's the support? What's the culture of an organisation in relation to business development? Now, I'm going to talk a little bit. Any Monty Pythons in the room? You're Python-esque, are you? I want to show you this video about change. Yeah. We won't even show that video. Everyone sits in it. Oh, I've got a chipper. Yes, I've got a chipper. And everyone, I think, around this table has a chipper in their organisation. And we may laugh at that, but it actually has a sense of very good message in relation to change. As I said before, change for change, take it not board. Did I say it before? I did. It's inevitable in everything that you do. The thing about change is that generally our external influences change the way in which we need to operate in efficient manner. It could be our banking system. The banking system was the biggest change forced by the industry. The gap in online transfers and the way we do things, all that sort of stuff. And in our particular case, the biggest change for influence of us is governance. Because we're so reliant upon government in relation to our systems and process for talking. So we are going to find these chippers in our organisation. Briggs theory of transition change management, with a psychologist. And he draws this graph in relation to the psychological change of the change management and the emotions that take place in relation to change management. So here we have what's called the ending phase. Something sits up there and say, what we are doing is going to stop. And over here we've got called new beginnings. And what happens with performance over time for the ending phase of new beginnings is that productivity falls off generally, right? And it gets to the bottom, and this is called the neutral zone. And all of a sudden, or whatever reason, we head up to new beginnings. People become more excited, etc., etc. Now, if you look at that graph, some people may take 1 minute to get from the ending phase to the new beginnings. Bring it on. Look now. Thank you very much. I want to run with this. Some people may never ever get there. Some people will end up at the new beginning, at the ending phase, or they'll get down to the neutral phase where the productivity's fallen off. So what excites me in the next phase? Generally, new software is that classic example. The ending phase. You've used that all these life. Oh, no, I don't want to get involved in this new one. Oh, no, I can't go through as well. So start to think about the emotion component of the end of anything which we do in regards to human development and change management process. We have an obligation as a practice manager and owner to assist people in that transition, to support them from getting from ending phase. Remember, ending phase is about grief. It's all the components of grief, of loss. If you understand what loss is all about, and grief's all about, that's the ending phase. Got to let go. So start to think about Briggs. It's a great graph to look at. When we look at the start on, we touched on all those ones previously. The staff development. Your vision will only work if there is shared expectations. I cannot deliver the total vision. I'm only one part of the vision. Everyone in the organisation has a responsibility, whoever it may be. My cleaner is part of that vision. Because, classic example, what you walk past is the standard that you set. You walk past that piece of paper sitting on the floor in the waiting room, that's the standard you set. And everyone will walk past that piece of paper. So part of your vision, part of the whole component of staff development is so important to deliver the message. We've all struggled, haven't we, in relation to, since COVID, in relation to employment people. For some reason, I don't know where all the skill set's gone. We had it before, we don't have it again. I don't know. What happened to this? Every industry, where did all the baristas go? I love backpackers, weren't they? They stayed away. Where did all the hospitality? Where did all our receptionists go? Where did all our nurses go? So our workforce planning becomes really important in relation to deliver of our vision. Do you invest in education and training? Well, it must be because you like it. I pay my staff the things that they do outside hours. I pay my staff to come to staff meetings. As a laugh, I pay $50 plus a meal to come to staff meeting. My little trainee, Mr. Smith, yes, Megan. Can we have more staff meetings? I make more money coming to staff meetings than I do on a couple of them. How true that is. So where's our investment? I can't stress enough, as owners of the practice or you as a manager, please consider what is your ongoing education and training should be part of your budget. It should not, which we'll talk about in a moment where we get there, Jen. Which should be part of our, because part of our employment cycle, right, which is employer retention, all that stuff, is actually workforce planning. Part of a module in relation to my employee cycle is workforce planning. Am I training that person to do something else in the practice? Am I introducing them in relation to new skill sets and knowledge in the practice? Have I identified that reception to do the NPA course? Have I upskilled one of those receptionists to go and look after the debtors on a Friday afternoon? But the big one is, have I trained someone in recalls? Is it a dedicated person? Because where are we going to get the court, Jen? I'll tell you now. Jen looks after the recalls. Oh, she's done 2 weeks. I'll worry about it.
I am actually.
I know. I'd say Jen will look after the recalls when she gets back. And Jen gets back in 2 weeks' time. She's mounting the emails she can't bloody jump over. And she might get the recalls 2 weeks after she gets back. So she's 4 weeks behind in recalls. Time value of money. So all of a sudden now we're 4 weeks behind in that chain of. So we're now going to have to start to think about a dedicated person. Recalls. Time put aside, not by the reception front desk, corralled time to make those calls.
Everyone's going to be out.
Oh,
PHMs.
have I got a deal for you? No, we are, Jen, you're right. It's going to be an important part. You watch My Medicare roll out. Wait till we now the next tranche of what My Medicare is going to look like. Now we've got the item numbers, which is interesting. As an aside, listen to this. I shared this with Tim just a moment ago. There with me for one. It says there is item numbers, develop a GP chronic condition management plan face to face. Develop a GP chronic condition management plan. Telehealth. Item number for that. Review of GP chronic condition management plan face to face, and item number for that. And review of a GP chronic condition management plan. Telehealth.
Whether they perhaps or meaning it. But for their heart. But it's.
Right, trust in the room.
Reputation.
Any thoughts?
That's good. She would.
Can I be honest with you? No idea. So I know nothing about item numbers in my practice. Wait till Deb comes back.
Yeah,
Yeah,
actually,
yeah.
also put it on the practice managers from giving.
Oh, on the practice management form, you always get the version of use. Because it's a personal interpretation accordingly. The only way it works, of course, if you wish to ring MBS online and get a view from them.
That's good.
But phone 3 times, I say, with 3 different answers. That's the only, because there is always going to be interpretation of the MBS description. There's always been. The only way you can get an answer is phone me twice. It's two versions.
Just aside.
Another aside.
Yeah. If you are getting advice from the MBS around MBS item numbers, there's that ask MBS.
Ask MBS, yeah.
Could use that because you get it in writing.
In writing, yeah.
Because it's right. It depends on who you talk to if you call them, and
Yeah.
then you've got nothing in writing to say that that's what you're told. So
I can't answer that because I don't get involved in items on the
I
table.
think a lot of practices were audited on 10987 number and they had to give the money back.
Oh yes, definitely. I must admit,
yeah,
Yes.
I would get everything.
10997, the audit took place and they claimed back quite a bit of money for
And
10997.
whatever explanation you
Yeah.
give, it's one-sided.
Yeah.
You can't argue with that.
So a part of what we do is financial management. And I don't know what frameworks you use in your practice now, if you're a practice manager, depending upon that word we call trust, whether your principles of your practice allow you to do certain things in relation to financial management in your practice. They may or they may not. That's fine. That's an individual decision. But I'm going to cover off on some of these, the basics of financial management. When we look at what our responsibilities may be, we accounts payable and receivable, whatever that looks like. Come back to that in a moment. Cash flow management. I see on the practice manager's Facebook site last night, people are asking, when's the PIP here? When's the WIP here? Oh no, I need the money. I'm saying, well, it's interesting that we rely upon government funding to fund our operation of our practice. And that's a real, I'm not saying it's right or wrong, but it's sad that we have to allow for the PIP and the WIP to actually fund next week's pays. Right? So where's our financial stewardship fit in this? And what's our role as a practice manager? To sit down and say, how do I look at the management of cash in the practice? When do I need cash in to pay that bill? I know that, in July, it's a big month for me. I've got no money left because I've cleared it all out to the directors of the company. Nothing left, but I know this 1st of July, I've got my insurance is due for $15,000 worth of insurances. I know, my rent's due, 2 lots of rent are due on the 1st of July. Where's my money comes in relation to this? Because I've cleared all the cash flow money out by June 30th. So how do we, as a manager, start to think about our cash flow management? How do I fund things? You don't have to tell me if you don't want it. It's a rhetorical question. How many people actually do budgets? How many people actually do cash flow statements? These are very critical. Can you read a balance sheet? And I think I'm a balance sheet person. I couldn't tell about problems. You know, balance sheet is the most important part, I think. Balance sheet tells me how viable my organisation, my practice, my business is. Any loans that I need, the balance sheet, the bank manager will like the balance sheet. Cash flow projections as well. So start to think about what's this whole aspect of financial management we need to in our practice of this. Of course, the big one for us is the reports and dashboards, these extractions from third-party extraction. These things now jump up on our screen and gives us real-time key performance indicator. How am I going with this? What's my actually building up to the second? You know, what item numbers I need to? What's this patient I need to do a care plan on this, etc. These dashboards now are reality in our data. These extractions. There's a number of them around. So we need, and there's going to be more of them around, I think. So reports and dashboards. Simple things like, I don't know about you, but I do with my registrars. I actually do performance appraisal, item number analysis. It's interesting when I sit down and do an item numbers of analysis of my supervisor, and I do the item numbers analysis of my registrar. And when they sit and they look at that and they say, "Oh, I didn't know I could charge it like that." So even down to things of comparing item number flows between registrar and their supervisor. It's a massive incentive. I'll give you an example. I did this the last supervisor did a couple of times. They increased their billings from $68 per patient to nearly $79. Only because they realised there are other item numbers that they could charge that they weren't charged. They didn't know. So the things like that. Are you one? How are you going to 1091%? Well, add 5. How have I got now? What's the framework around that? Have I got a care plan? I charge the 10997. Am I adding on? I'll give you an example. Someone comes in for a GPMP by nurses. By the time they add on the ECG, because that the guidelines allow, it's part of that. By the time they do an ABI, and they can break it on the index, $55, etc. That consultation really goes $450. By the time you legally and under the MBS can add on all those other item numbers, which you're entitled to do, it's $450. Now that is, are you capturing all? Are you capturing all? I don't know. So when you're thinking about reports and dashboards, when we talk about reports, it's called benchmarking. Two types of benchmarking, internal and external. Internal means to compare myself against myself. External said I'm comparing myself against someone else in the same industry. Do you compare yourself against yourself? You do? No. This is what you're going like that. That's great. This is about CQI, continuous improvement. Setting a system up where how do I go against last year? How am I going against last month? PDSAs, Plan Do Study Act. You know that would be PDSAs for quality improvement. You've got to say yes with the PhDs here. You've got to say yes. All the investment into PDSAs over the years. That's measuring your performance. And that could be clinical performance or it could be financial performance. It's up to you. We introduced PDSAs, don't we, when we had BMIs up. I did a report the other day. BMIs greater than 30. Doctors, can you tell me? And then I had to match across the ones who were on care plans. And I've still got about 530 patients with a BMI greater than 35, that aren't on any plan at all. But all of a sudden now, it'll be 2 weeks' time. So what are you going to do with 35 plus BMIs that aren't on plans now? What are you going to do with this? Clinically, what are you going to do with these people? Can I deal with these people now? Can I put them into the appointment book system? So it becomes an operational component after that. Well, I've done the identification. What do I do next? Doctors want to know, all HbA1c patients are more than 10.5. Yeah, I can give you that. What do you do with it? So think about I generate figures for figures' sake. And that's what these reports do. What do I do after that? Do I have the capacity and the skill sets and the knowledge and the energy and the infrastructure as a cost to deal with those, whether that's BMIs 35 plus, I've got those 10.5 plus in relation to HBLCs. So think about reports and dashboards. They're great having them, but what do I do with them? And then the business finance as well. So when we're talking about the practice income, well, we get practice revenue from a whole stream. And I think the time has come, and I'm going to say to you that with my Medicare, we're going to have to monitor our revenue streams from a whole range of areas now. It's just not PIP money coming in or WIP money coming in or fees generated. I actually think now that we're going to have to seriously consider measuring the respective streams. So in your revenue statements, because you're going to have to make a decision to practice. I think it's important that we actually have our financial goals. Remember, I spoke before about our vision, our mission, and our goals. I spoke about financial and non-financial. Well, what do I want to achieve financial in the practice? Yeah, sustainability, liability. I understand all that. But it's actually more than that. Where's my investment? Where's our investment back into the business? Where's my investment back into the business? And this is not about it's about profits. Well, what comes first, the chicken or the egg? Now, if I've got my office manager been there for 36 years, my supervisor 37 years, office manager 36 years, supervisory nurse 36 years, etc., the cost saving of not having to employ people, that process has been astronomical. So the cost to retain, that may cost you to retain. What's the cost of me to retain my staff? Okay, I might spend maybe $15,000, $20,000 a year on my staff to go out to shows, out to dinners, movies, buses here, whatever it may be, Christmas functions, birthday function. Anyone's got a zero after their name, after their birthday, gets a weekend in the city, some hotel and dinner paid for there and their partner, because got a zero after their birthday. Their age, that is. What's that cost me? Not me. Practice. Nothing. And the cost. What's the cost to keep it? Your role as a practice manager, in your practice management role, leadership role, says to your owners, give me $1, boss, and I'll give you $1.25 in return. If you say that to your owner, they're going to say, I can only get 4.25% of the bank in relation to invested money. I can get 25%. Your role is how do I find that 25 cents on the dollar? And that's what my role is. Where's the return on investment to the owner? So part of financial goals and plans, what are yours and mine as things called KRAs and KPIs? You know what KRAs are? Key result areas. These are the areas I need to perform in. Key areas: financial, human resource management, information technology, customer service. They're KRAs. What am I being measured from under each one of those KPIs? No, KPIs don't, key performance indicators. Under financial, what are the things I'm going to have to do? I'm going to produce a profit and loss each month. I'm balance sheet every quarter. I'm going to produce an item analysis every month. I'm going to blah, 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 blah. And when my performance appraisal is after my discussion with my principals up there, how'd you go? Oh, I did that, I did that, I did that, I did that. Fantastic. So where are your KRAs and your KPIs when we're talking about our financial goals? I always was ahead of myself. I just want to spoke about that just there. So it's about financial performance KPIs. Patient satisfaction is a good one. Do you measure your complaints? Are your complaints you got today higher than what they were the same time last year? Patient satisfaction is a big part of KPIs. So what sort of leader are you? What sort of leader are you? Every one of us has a different leadership style. And you could be autocratic, democratic, situational, a whole range of different leadership styles. I'm a situational leader. my leadership style will change depending upon the situation that we are in at that point. For instance, I can be autocratic. I say, hey crew, as from the 1st of September, this is going to happen. Because I have no control over this. Government said September the 1st, this is going to happen. Or I can be democratic and say, hey crew, next year my Medicare is coming in. Let's talk about this. Here's a framework. What do you think about this? Fine. So that's a situational leader. Situational leadership style will change depending upon what's required at that point in time. And we all have these different, but the great thing about situational leadership is the fact that you need to understand the emotional intelligence of the people who we are dealing with. I can't stress enough. Anyone know of MBTI, the Myers-Briggs Typology Indicator? It's an indicator of characteristics, and it's internationally well known. I'm not going to get too much detail, but I'm an ISTJ. What does that mean? I'm an introvert. People find it hard to believe, but I'm an introvert. Classic terms. And sensate thinking, judgment. Not judgmental to be judging you, it's about authority and how I align with authority and etc. etc. Now, as a manager, I've got different characteristics like you in the workplace, and they all think different. They all think different. Motivation for one is not the motivation for another. And your challenge and mine is how do I understand everyone else's characteristics to achieve an outcome? It's not great leaders do. It's what leaders do. I'll give you the difference between introvert and extrovert in achieving an outcome. I'll say to an extrovert, oh, look, can you give some feedback regarding A? All of a sudden they'll go, and I'll throw these things after all the options. Thank you, no, I really appreciate what you've done. Thank you very much. And I'll take all these initial thoughts, not thought through, but those initial brain dump. That's what extrovert will give me. I'll say to the introvert, that's what I'm thinking. Can you help me on this? Thanks, Gary. I'll tell you what I'll do. Leave with me overnight. Back to you tomorrow morning. Tomorrow morning, I'll get an A4 page, 12-point font, 1.5 line spacing, Arial, with a margin, and I'll hand it to you. Well thought through.
Yeah.
So depending on what I want to achieve as a leader, depending upon who I ask and what I ask, emotional intelligence plays a big part in relation to leadership and the skills based around that. Sorry?
Session 3 is emotional.
Oh, am I doing that?
No.
Oh, I thought I did. Sorry, as an aside, enjoy this afternoon about emotional intelligence. I'll go play on you. So I can't stress enough in relation to leadership is really around how do I get someone to do something? And I won't get into too much detail because we covered it this afternoon. But your role, you say to yourself, well, strategic planning. You've got to lead the vision. Someone's got to lead the vision. Operational oversight, yes, you've got to, how do I make things work in our organisation? But remember, part of change management and operational oversight is really around reviewing of systems and operations in the organisation. Because I've said a number of times before today in this session that we're going to actually have so much change happening. How do I make it change accordingly? And of course, there's no use dealing as a manager, leadership, in relation to operational oversight, change management, unless we actually build the team and provide the education and training to do. Now, for accreditation purposes, there's a section in there that talks about indicators of staff training, provide training in relation to the type of work that they do. Remember that this is not about external training. This is about internal training as well. So you keep training matrix of things you train your staff. How to use Tyro, how to use a FPOS machine. That's internal training, and that's really important. That's specific to the role of that particular person. So start to think about what training do I need to support the staff in relation to change management and change in the system. I think one of the advantages in my practice is the fact that because I'm part of change at varying levels, all the boards that I sit on, the knowledge I've got, I can start to change thinking years in advance. So when it does happen in our practice, there's only that last hurdle. Staff are already aware of the changes made. This is about change management as a result of planning versus reactive. Active planning and reactive planning. Management by planning, management by crisis. Australia used to be, other than Sweden, used to be the number one in the world in management by planning. We're number two. Now, so those four areas are critical in regards to what your role as a leader in your organisation or a practice manager in your organisation. What I'd like to do now is finish off with one of my favourite YouTube videos.
For one submarine, my guys were trained to do what they were told. That's a deadly combination. We all know organizations where people just follow the leader into disastrous situations. So I got my guys together and I said, hey, we've got a problem here. I was trained for another submarine. You're trained to do whatever nonsense comes out of my mouth. That's right, Captain. I mean, they knew. They already knew. I was pretty much talking to myself. So what are we going to do? What are we going to do, guys? And we talked about it. Okay, what I really wanted to do was get ready for the inspection. We were sitting in the wardroom. We spent a couple hours. We were talking about it. And we came up with all these different things. And, well, Captain, you just got to be smarter. You got to give better orders. Like, well, how am I going to learn a whole nuclear submarine, miles of valves and pipes? I spent a year learning Olympia, 2 weeks over here. So in a year we'll be safe? That's not going to work. We had to deploy the submarine in 6 months. So we talked about it, and they said, okay, there's only one logical solution. We figured it out. They're pointing at me, you shut up. And I thought about it. And you know what? They're right. So at that point, I vowed never to give another order. And if you came down on my submarine, it'd have been very confusing because you couldn't have pointed. It'd have been hard to say, well, who's the captain here? Because you wouldn't have seen me giving orders. I did retain one order. The final order to launch a weapon, a torpedo or a missile, I kept with me because I felt that since that was going to result in the deaths of other human beings, that I didn't want that on anyone's conscience but mine. That was my moral and ethical responsibility. But even though everything else in the Navy, there's long lists of things that says the captain has to authorize. Captain should authorize. You got a couple nukes in your group, they'll tell you it's true. Captain authorize, submerge the ship, get underway, start up the reactor, shut down the reactor, connect to shore power, divorce from shore power. On and on, break rig for that, on and on and on. Pages of these things. I just refused to give those orders. What we replaced them with was intent. Instead of giving instructions, if you want your people to think, don't give instructions, give intent. So they're kind of, hey, what do you want me to do? Well, left full rotor, steady course 255. No. So what are we trying to accomplish here today? Well, we're trying to get in position so that when the enemy submarine comes through, okay, so where do you think we should position the ship? Maybe over here. Good idea. Go there. You give intent to them and they give intent to you. So my officer stopped requesting permission. And every other submarine, Captain, request permission to submerge the ship. Submerge the ship. Submerge the ship, aye. On Santa Fe, Captain, I intend to submerge the ship. Very well. And they did it. And it might seem like it's a very small, nuanced change of language, but it was hugely powerful because the psychological ownership now shifts to them. They need to discover the answer. Otherwise, you're always the answer man. You can never go home and eat dinner. And so we started doing this. And it was hugely powerful. Actually, we went another step. Then I got smarter and I said, when the officer said, Captain, I intend to submerge the ship, I would ask him, well, what do you think I'm thinking right now? And he'd look at me, hard to tell. I'm guessing you're wondering whether it's safe. Bingo! I said, well, convince me it's safe. I said, Captain, I intend to submerge the ship. All men are below, hatches are shut, ship's rigged for dive. I checked the bottom depth. the submarines in the water that's been assigned to us. Then then later I'd ask them, is it the right thing to do? And they would say, well, yes, sir, because our mission requires that we, and these are the two pillars that I think support this idea of giving control. These are the two pillars that need to be in place. The technical competence, which is represented by, is it safe? And the organizational clarity, which is represented by, is it the right thing to do? And you put those things in place, and then you can give control. And you give control, and you put those things in place. And you are off to the races. So think about what's happening now. My officers are starting to think like me, because I have to think like, where should we do the ship? And so the guys below them. Now this took 24 hours to happen. It took a couple years for the full implementation, but immediately there was change. We received another inspection. A year later, we received an inspection. The inspecting team gave us the highest grade they had ever seen. Not that year, not the Pacific, ever seen. Why? I mean, this crew had a captain who was a dummy. It's because that needle started moving up. And on another submarine, there was one guy in charge, one guy giving orders, one guy thinking, and 134 people doing what they're told. I don't care how smart you are. On my submarine, I got 135 thinking, active, passionate, creative, proactive, taking initiative people. It's a tidal wave. You don't stand a chance. Here's the solution. Move the authority to where the information is. You mean the software engineer can decide whether we ship the software? Yeah. You mean the client, my salesman can close the deal? Well, up to $1,000. No. Yes. Whatever the price? Yes. What does it take to make that happen? Now, if you're picturing a lot of people out there doing crazy things and a bunch of arrows going in a bunch of different directions, you have the wrong picture. You create the environment so that those people are out there making decisions as if the CEO were standing right behind them. And if it's not the same decision, it's actually a better decision because they have the information. And not only will you get better speed of execution, because now you don't have this delay, what happens is those people feel like they matter because they're thinking. You engender thinking, you create the environment for thinking. The secret is nothing I said is hard. There's nothing hard. The only thing that's hard is you. It will feel wrong. You've been genetically and culturally programmed to take charge and make it happen. Take control and attract followers. What you want is to give control and create leaders. It will feel wrong, and you will repeatedly start down this path if you so choose, and then you'll be angry at yourself like I was, and you will have a failure, and you'll go back to the old ways. And you will pick yourself up, and you will go again. You will go again. And by doing so, you will achieve the greatest thing possible. You will have achieved greatness, not because of the deeds and acts that you did, but because you set an environment where the people around you and their families and their schools and their organizations and their businesses, they've achieved greatness. That will be the greatest thing of all. Go forth and be great.
What a great clip. It really is. And that's a true story. He was captain of a nuclear submarine. Take my message for that really is around empowerment delegations. The challenge of empowerment and delegation, as he said in there, was really, am I providing the skill sets in the empowerment process? That empowerment delegation process will fail unless you provide the skill sets and knowledge to the person who you're delegating to. And as a leader, that's what your role's about. How do I provide that framework to allow other people to work to their best ability by providing the skill sets and knowledge from our impact? Well, thanks very much.